Great. Thank you, Melissa. I am very, very honored to be a member of the pancreas team at MCW. I have been here at MCW for quite a while and have just loved coming to know many of you. As you all know, when you're diagnosed with pancreas cancer, it's a turbulent journey, and being part of the team that helps to get you through that brings me tremendous gratitude to you for sharing your cancer with our team and letting us take care of you. What I'd like to do today is talk a bit about radiation for pancreas cancer, perhaps familiarize you with some of the terms and what we do to create a radiation plan for you. You will see some words on the PowerPoint. We can't quite figure out how to stop that, so hopefully it's not too distracting, and we'll carry on despite it. Here is our beautiful cancer center at the Medical College of Wisconsin. The radiation oncology department is on the 3rd floor. Radiation oncologists train like other physicians. We go through training through college, medical school, and then residency, which is now 5 years. Rarely fellowships follow for a year or two. And we devote our careers to treating patients primarily for cancer, although there are a few benign diseases that are treated with radiation. When we're a part of a cancer center, the wonderful thing about it is that we're part of a team. And those people with whom we work have great expertise, whether they're surgeons, medical oncologists, nurse practitioners in all of those specialties, nurses, therapists, techs. It is a fantastic team. And we have state-of-the-art technology to help you. And we practice with the best contemporary practice standards. And at the medical college are always involved in evolving innovation. It's very, very important. We don't want to stay static. We want to improve and bring everything we can to our patients to cure their cancer. When we look at pancreas cancer, all 3 modalities are needed. That is chemotherapy, and you'll hear about a surgery last approach with pancreas cancer. So we want chemotherapy first, followed by radiation with or without chemo. And surgery is the last step in the process for most of our patients. So as a radiation oncologist, how do I best help you in fighting pancreas cancer? What tools do I need to do that? Radiation oncologists need to be able to see what they are doing. That is, we have to be able to find, localize, and treat the tumor in the pancreas and the other tissues that could be at risk of harboring microscopic cancer cells. And we also want to see the normal tissues, such as you see here, the stomach, the duodenum, the small bowel, all of which live very, very close to the pancreas and could suffer collateral damage if we don't carefully plan the radiation course. We need to know, not only before we get started, but while we're treating you, that the radiation is hitting the tumor during your course of treatment, as that tumor may move inside of you and change in character. And we also need to know if the normal organs close by, such as the kidneys, the liver, the bowel, stomach, are being spared so that they're not getting as much radiation as the tumor. And this is what we refer to as image-guided radiation therapy, where we use radiologic images to plan and deliver your radiation. And this is how we see what we're doing, and that we're accomplishing what we think we're accomplishing. When you come to us initially, you're going to meet us in consultation. So that's your first visit You're meeting all of the team members. You've likely met the surgeons and the medical oncologists, and you'll meet us. We'll go through a regular consultation where we talk with you and examine you, and then we plan what's called simulation. That's where we do the actual planning that consists of either a CT or an MRI scan in the treatment position. You see this patient laying down on a table that looks like a CAT scan table, arms above the head, out of the way of where the radiation unit is going to go, knees comfortably resting on a cushion. There may be, when we do a simulation, there's a little belt that goes around you that helps to monitor respiratory motion. Before we get you into the CT or MR simulator, you're going to drink some oral contrast. That's so I can see your stomach, your duodenum, which lives right around the pancreatic head, and your small bowel. And we'll also have an IV in place either in your port or your arm to deliver IV contrast, because we want to see those big blood vessels that live near your tumor. They will be targeted along with the tumor. As mentioned, your arms are going to be above your head, and we fabricate either a mold. You see here this white material that molds around your shoulders and arms, or a special wing board that's MR safe metal stand that your arms go in and that your hands grasp onto to keep your arms out of the way of where the radiation machine is going to be coming to deliver dose. And we do both 3-dimensional and 4-dimensional CAT scans or MRI scans to locate your tumor and assess how much your pancreas is moving while you breathe. Your diaphragms move all of the abdominal organs, including the pancreas, and we need to account for that as we're doing your radiation planning, because we don't want the pancreas to hop in and out of where the radiation beams are. When we obtain CAT scans or MRIs, we use these as the basis for your plan. So on each slice of the CAT scan, the radiation oncologist will contour your pancreatic tumor, the blood vessels that live near it, such as the celiac artery, the superior mesenteric artery, the superior mesenteric vein, the portal vein. These are all structures that we recognize on those scans and contour. And we also contour normal organs: stomach, colon, small bowel, kidneys, liver, spinal cord. And we have an army of individuals who work on this. They're called dosimetrists and physicists, who create the radiation plan from the anatomy that we have contoured. And we have a iterative process where we tell them we want to give this much tumor or this much dose to the tumor, and this much dose the normal organs can safely receive. And a plan will be created that tries to achieve those two competing goals. In some patients, we use MRI-based planning. And the reason for this is MRI can be very, very helpful in defining the tumor, sometimes even better than CT. Here's a patient with a round, bright tumor near the body and head of the pancreas. Right by it, we see the stomach and the duodenum. And for this patient, we want the high dose right around the tumor, but we have to very carefully spare the stomach and the duodenum because they will not tolerate high doses of radiation. These lines that you see here are all different beams that come in from many different angles to treat the tumor and spare those normal organs. Once radiation is planned, it needs to be delivered. And typically, radiation is daily, 5 days per week, for 3 to 6 weeks. If we're doing conventional, what we call chemoradiation, once a week, you're going to get a low dose of chemotherapy called gemcitabine, and that makes the radiation work better. It increases the susceptibility of those cancer cells to dying. You'll either be treated with what's called 3D conformal radiation, or more commonly, IMRT, which stands for intensity modulated radiation therapy. And here you see a patient lying on a radiation table, and there's snapshots of the linear accelerator going around the patient and delivering dose at individual stopping points within 360 degrees circumference of that patient. The ability to do this is related to how we shape the beam. And we talk about intensity modulated radiation therapy, where up in the head of that linear accelerator, there are a series of little leaflets that open and close and produce different shapes depending upon which angle the machine is at, so that more dose is delivered in some angles to the tumor and less to the normal tissues. It's why we call it intensity modulated, because we're modulating or shaping the dose so that we don't hurt the normal tissues and we treat the tumor. And in the process of doing that, we get a very, very conformal dose right around the tumor rather than spreading it all across the abdomen. So it's very, very specific to each patient, crafted for every patient's tumor and normal organs. There's another type of radiation you might hear about, which is called SBRT, or stereotactic body radiation therapy. And that's radiation given in larger doses and fewer treatments, usually 5 or less. And you'd come in every other day over a period of 2 or maybe 3 weeks. It's meant to give a high dose to a smaller volume with tighter margins. So here's a pancreatic head, but we're targeting only a small portion of that head where the tumor arose near a stent. And the reason those margins are tighter is that the dose is higher per treatment. And we want to make sure when we give those high doses that we're avoiding the colon, the small bowel, and the duodenum and stomach, as well as important structures like your kidneys. All of our radiation, whether it's the 3 to 6 weeks or the 5 SBRT fractions, is image-guided radiation therapy. And what that means is that every day when you get on either the CT-based linear accelerator or the MR-based linear accelerator, you're going to have a quick scan that's done first to verify that your tumor is where we think it is and that your normal organs are where we think they were on your planning scan. And that scan is done every day, and the structures from all of those CT scan or MR scan slices are superimposed on that new scan, and we see how everything aligns and adjust it as needed. That gives us the confidence that your radiation is going where we think it's going, and is going to be very effective rather than morbid. Now, all of these decisions about how we care for you come from our multidisciplinary cancer team. And this is just a small representation of our team. Our team is actually very, very large. Every Friday morning, we meet at 6:30 a.m. as a team, and we talk about our patients. We talk about how we're going to sequence their treatments. Chemotherapy first, we mentioned, followed by radiation, followed by surgery in most patients. But there's lots of discussions about how many cycles of chemo, depending upon how the tumor is responding. There's discussions about whether surgery is possible or whether radiation is going to have to be given at a higher dose, which we call definitive irradiation. We also talk about what clinical trial you may be able to participate in, because we know that clinical trials offer the best of what is standard, plus what's maybe going to be even better in the future. So very, very important to participate in clinical trials if there's one available for you. And it's our job to explain those trials to you so that you understand them and feel comfortable participating. Most of the radiation we give is preoperative in nature. It's very rare that we give postoperative radiation, and only when surgery is not possible do we give definitive or high dose radiation. So what's our role when we give preoperative radiation? Well, what we're doing is securing the borders for future surgery. So here we have a patient with a pancreatic head tumor, and there are blood vessels that live close by. There's the duodenum and other portions of the GI tract. What our surgeons are hoping is that if we give the radiation, we're going to make it easier for them to remove the tumor with clear margins. That's very, very important. Having negative margins where there's no cancer where the surgeon cuts improves survival. Radiation also can deal with either visible lymph nodes or microscopic lymph nodes, and lots of lymph nodes live right by the pancreas. Those are removed along with your pancreas when our surgeons do their great work. And radiation can sterilize those microscopic lymph nodes so that they're no longer positive when they're examined. And that also improves survival. The fewer the lymph nodes, the better. Preoperative is much better than postoperative irradiation in helping our patients. We talked about targeted radiation, and what are some of the things we target? Well, here's a patient with a pancreatic head, and there's a stent in it because the bile duct was blocked. We want to target that. We've talked about the celiac artery. We put a margin all around that. That's called the PTV, the planning target volume. We want to be careful of bowel that's close by and minimize dose to that. In this panel of images, you're seeing again the pancreatic head and the superior mesenteric artery and vein. Those get targeted along with the head and head tumors. And all of that is encompassed by this planning target volume that needs the dose. We do have a trial in the preoperative setting, and some of you may have heard about it. It's called the SOFT trial. This trial is comparing that SBRT approach that we've talked about with conventionally fractionated radiation therapy. So 5 radiation treatments versus 28 or 5.5 weeks. And the goals are to compare quality of life outcomes for our patient. We also want to look at toxicity and other outcomes, and also look at the changes in the imaging that we get if you're on the MR Linac. How are those daily MR scans changing over the course of your radiation? Because there's some hidden secrets in those scans that may tell us how well you're going to do. Postoperative irradiation, as I mentioned, is rare, and that's given after surgery. I would say rarely when we encounter patients who on many attempts do not have a tissue diagnosis of cancer, where despite the GI doctors doing their guided biopsies, we can't prove that a patient has pancreas cancer, then surgery is used first to remove the tumor and confirm the diagnosis. Typically then, chemo will follow, and radiation can be used postoperatively, post-chemotherapy, in the event that there are microscopic cells in any of the remaining tissues. But we try, whenever possible, to avoid a postoperative approach with radiation, as it can cause more morbidity. What about definitive irradiation? So this is a situation where patients have a tumor that's too advanced for surgery, or they're not up to the surgery that could be done because of other medical problems. And we call patients who have tumors that wrap around the blood vessels that can't be removed. They would be called locally advanced. As mentioned, some patients are too frail, two different categories of patients. Typically, for the locally advanced tumors, patients will have months of chemotherapy first in an effort to downstage the tumor and potentially allow that patient to undergo future surgery. If it's still not possible for the patient to have surgery after months of chemotherapy and the surgeons declare the patient inoperable, then we will use radiation to try and ablate what remains. That is, kill the cancer cells in that pancreatic tissue and the associated blood vessels. Most of the time, this is done with concurrent chemotherapy, unless we're using that SBRT approach. When we do dose escalated radiation, we want to give a higher dose to the tumor, and we'll give that to a very small volume, and we'll give a lower dose to the surrounding tissues. We use both CAT scans and MRI scans to define the tumor, and we want to be very, very careful of the adjacent normal organs, such as the stomach, the small bowel, the kidneys. And we also have to be very, very careful about motion management, because when we're giving high doses, if the tumor is moving, we need to know that, and we need to know how to adapt the plan so that the normal tissues close by don't get that high dose. So what are the challenges of dose escalation? Well, one of the things is seeing the tumor. Pancreas tumors sometimes are a bit sinister in that they can blend with the normal pancreatic tissues. And if we look at CAT scan series, about 5 to 14% of pancreatic tumors are not visible on CAT scans. They can be seen on endoscopic ultrasound most of the time, and this is what's used to get the biopsy, but we can't use endoscopic ultrasounds during radiation. So we rely on our imaging, we rely on CAT scans, PET scans, CT, all of those to define the tumor. We find MRI to be very, very helpful, and as kind of a segue into MRI-guided dose escalation. With MR, we can separate the normal pancreas, which is rather bright, with the dark tumor, and draw a distinction between those two entities so that we can focus our radiation on exactly where the tumor is. On MRI, we can also see where the duodenum is, the colon, the stomach, and small bowel. And that helps us to avoid those structures when we're giving high doses. If you come to our department for MRI simulation, you'll go from the CT simulation room across the hall to the MR scanner, and we will scan you in the same device that you're scanned in the CT room, but an MRI will be obtained that we'll use for our planning. With the MRI, some people are claustrophobic, so we always ask about that first. Some patients might need some relaxing medicine to be able to go in the MR scanner, and some patients might need to actually be completely sedated. If you have to be completely sedated, it won't be feasible to do that all during your radiation on the MR Linac, and we would probably choose not to do MR guided radiation. What we get from the CT and MR scans is a panel of images that you can see here. And on each of the different slices, certain things are seen better. So on the MR, we can see your tumor better and your normal pancreas. We can see your duodenum. That's very helpful. The kidneys are easy to see on all of these images, and the spinal cord. But where MR is our real power player is in defining your tumor. We've just closed a protocol. We've talked about clinical trials that was looking at MR guided dose escalation for patients with unresectable tumors. I was the PI of this study, and we had 4 different doses that our patients could receive that were higher, much higher than preoperative doses. We closed this trial in late 2022, and our analysis is ongoing. So right now, if you have an unresectable pancreas tumor, we would treat you off of any clinical trial using the most current doses that are being used for this disease stage. And this gets into a discussion of what's been happening over time. When we created our clinical trial, we were in this kind of medium dose escalation phase about 5 years ago. Since our trial was launched and now closed, other centers across the country have been giving higher doses of radiation on clinical trials, and these are now considered standard doses. So if we look at the upper part of this chart, we have a 5-week course of dose escalation, a 3-week, and then the SBRT options that we're using off of any study because those have been proven to be very effective on other people's clinical trials. How do we decide which of those 3 options you will get? It depends how close your what we call your luminal GI, your stomach, your small bowel, your duodenum, and your colon are to your tumor. If they're very, very close, you're going to get the 25 treatments. If they're a little bit further away, 15. And if they're even further away, the 5 treatments, because we're trying to maintain that balance of trying to cure your cancer, but not cause any injury to those important normal organs that live close by. We have had the opportunity to have an MR Linac at our institution. MCW and MD Anderson were the first hospitals in the United States to have the MR Linac. We've been using this for about 5 years. And this is a picture of the Unity. This is a linear accelerator with an MR scanner built into it. And this is especially helpful when we're trying to do dose escalation, what we've talked about, giving those higher doses, because we can see the tumor better with the MR imaging, and the software that's available on the MR Linac allows us to replan your radiation each day if we need to, if your internal anatomy has changed enough that a new plan is required. This is an image you saw before. This is a patient who had an MR simulation. We can see the tumor, we can see the stomach, the duodenum, the normal pancreas. Here's the gallbladder, the liver. And we can see beams coming from all different directions to get a very high dose in the center of that tumor, much lower at the edges where the stomach and the duodenum live. So this helps us to balance all of those competing goals of getting a high dose in, but sparing the normal tissues. One of the other features of the MR Linac is that while you're laying on the table, we can do a scan that shows how much motion there is. This is the heart, the liver, the pancreatic tumor, the small bowel, and we can adapt the plan if there's more motion one day than another day. So it really gives us that ability to protect the normal organs and treat the tumor to a high dose. And of course, this requires a team of individuals. We have brilliant physicists who have helped to make this technology possible. Our chairman, Dr. Schultz, Dr. Bill Hall, who some of you have as your pancreas doctor, Dr. Eric Paulson, who now is chair of physics here at MCW, and our wonderful therapists who take you back every day to deliver your treatments and make this a much more human experience. And it's this coming together of innovation and also warm-hearted individuals that I think is the perfect unity of skill and heart, mind, body, and heart. So that's our goal, is to see clearly and to push away those clouds that cancer brings to your life. Obviously, we want radiation to be a wonderful tool to help you on your journey. And that's all that I have.
Thank you so much, Dr. Erickson. If anybody would like to unmute themselves and ask questions, feel free to do so now. Otherwise, if you don't want to speak, you can drop your question in the chat.
Okay, hi, my name is Keith. I have a question.
Yes.
Early on, you said that this is primarily for pre-surgery. In my particular case, I am post-op, but now the track where the drain was coming out has a large nodule, which is cancerous. It protrudes. It can be painful at times. Is that ever an option for radiation?
Oh, absolutely. We do see sometimes that the tumor likes to track along those drain sites, and we can use a short course of radiation over about 2 weeks to help with that problem. So that's something, we don't encounter that commonly, but we have certainly seen that and helped other patients with that problem, Keith.
Okay. Very good. Thank you.
Yes, absolutely. And someone has their hand raised. Why don't you go ahead?
Hi, my name is Rahim. I was diagnosed with the pancreatic cancer in February 2003. And since after I've got chemotherapy, FOLFIRINOX, and gemcitabine, Abraxane for like 7 months right now, 10 cycles of those.
Yes.
And after CT scan I took a couple of weeks ago, it showed some good shrinkage, and my surgeon advised me to take some more Abraxane and gemcitabine. And after like a couple of next 2 months, I have to continue those, and then they get another CT scan. The original plan was doing the chemo radiation, 5 cycles of the radiation, like every other day, as you mentioned.
Okay.
After chemo and also the surgery. But after they checked the last CT, he told me, my surgeon, that if it's going to be more shrinkage we see in 2 months that I finish the chemo, they may not do the radiation. They just do the chemo and then go to for the surgery. I want to ask you how it works. So is it that okay, just cancel the radiation?
It's, there's mixed opinions. And usually, it's sometimes team specific how radiation is woven into the treatment schema. We at MCW it would be a rare day that radiation would not be used prior to surgery. There is a large clinical trial out of the Netherlands called the PRIO-PANC trial that has really given us good foundation for our adherence to using preoperative irradiation. Patients did better when they got radiation in addition to the chemotherapy that you described. So, I think unfortunately, there has not been universal acceptance of the role of radiation in the treatment of pancreas cancer. But if you would be at MCW, that would be what you would get. We're very passionate about it as a team.
Can I ask them to do the radiation even if they are not willing to?
I think you can, you always have the right to ask questions. The other option is to get a second opinion. Sometimes that's not possible depending upon where you live. There is a second opinion program here at the medical college, and I think the first step of that oftentimes involves not coming in person, but having your history and your imaging reviewed.
Okay, thank you.
Yes. So I don't know, Melissa, if folks need a phone number to call, can you provide that?
Yep, happy to provide that information.
Yeah.
Okay.
That's always, and sometimes that's enough to cause other teams to say, well, maybe we should be thinking about using radiation. It's certainly now part of the NCCN guidelines. That's the National Cancer Guidelines for how all different stages of cancer should be treated. So that's also something that you can bring to the discussion.
Okay. Thank you.
It looks like there's a comment in the comment section. It's from Mr. Hussein. Dr. Erickson, thanks for your team's care last year. I'm doing very well. Are you able to share any early insights from the SBRT trial?
Yeah, hello, Dr. Hussein. It's good to know you're on. We are going to be doing an interim analysis when we hit 80 patients on the SOFT trial. So that we're about, I think, 7 patients away from that. What we can tell you is it certainly doesn't seem that the SBRT is causing harm. Patients are tolerating it well, and long term, we're not seeing any adverse events from using it. What I can't tell you, and this will be part of the official analysis, is what the outcomes are of the trial, because we don't have the official analysis.
Thank you so much. Any other questions? All right. Well, thank you so much, Dr. Erickson, again, and thank you everyone for joining. Our next call will be next week, Wednesday, and we'll have Dr. Doug Evans, one of our surgical oncologists, who will be speaking about treatment sequencing. So that might be also applicable to some of you here today.
Yes.
Thank you so much.
Good luck to all of you. Yes. Yep.
Have a good night.